6 organisms now what? Quarantine in place. The moderator is Phyllis Weisberg, an attorney and partner with Montgomery, McCracken, Walker, and Rhodes. And we have a fine panel here. Each of the panelists will give you a minute on their background before they speak. And we have an engineer, we have a communications facilitator, we have someone who heads up and runs the Battery Park City CERT, much we can learn from, and we have someone who does emergency preparedness. And we have a doctor from the New York City Department of Health. So at this moment, I'm going to turn the floor over to Phyllis Weisberg.
Good morning, everyone, and thank you for coming. A lot of what we discussed today will have some bearing on bed bugs, food pandemics, mold, biochemical terrorism, and we will discuss those, but I think because of the flow of news, the initial focus at least will be Ebola. I'd like to give you a word of caution. The title and the subject of Ebola suggests some kind of sensationalism, but it is not intended to be. This seminar is not to cause you any panic or to cause you fear. It's an information-based panel to help you understand public health issues. Listen to the facts. Listen to what you're being told. Too many people are suspicious of those in authority or refuse to listen to facts. And there are many in the media and in politics who want to stoke those fears. Resist it. You're going to get some hard information today. Listen to it very carefully. Unfortunately, because of the misinformation out there, it's led to stigmatizing children. We've heard reports within the last few days of children in New York City being stigmatized because of their African background. There are children being kept out of school. There's, among some people at least, a general sense of panic. It is not warranted. We'll learn something today, and hopefully you will go back to your buildings armed with the knowledge so you can introduce calm and deal with issues as a measured response. As I've been reading the coverage about Ebola, it reminds me of the 1980s and what happened in this city about AIDS. There was a total panic. There were people who were stigmatized. Those were homosexuals, but those were also Haitians because of the prevalence in the Haitian community. It was, I think, a shameful time in the city's history. There were those in Congress who raised the same issues that are being raised today, which is we can't let anybody in who is HIV positive. And in fact, in the late 80s, Congress passed a ban that remained on the books, although it had not been enforced in many years, until 2010. Our fears were overwrought. AIDS was very serious. At one time, it was a death sentence, but it was not the types of contagion that the general public necessarily had to worry about. It thankfully no longer is that death sentence. And I hope we've learned from that and that we can keep that in our minds when we start dealing with what's being thrown at us about Ebola. I'd like to now turn the panel over to Dr. Amita Toprani, who is a medical director at the Department of Health and Mental Hygiene, who's going to give you the facts on Ebola.
Thanks very much. Can you guys hear me? Okay. So this is our sort of Ebola 101 talk, and I'm going to go through it sort of quickly because I think most of you already know a lot of this information, and we can leave a lot of room at the end for conversation. So this is the largest Ebola outbreak in history and the first one to take place in West Africa. It is currently getting worse, but we're sending lots of help, and other governments are also sending help, and that's what's going to stop the outbreak and also make it safer here. Ebola is a virus. It's different than a bacterial infection, so it can't be treated with antibiotics, and it is carried by animals like monkeys and bats. And it was first discovered in 1976 near the Ebola River in what is now the DR Congo. And since then, outbreaks have appeared sporadically in Africa. The symptoms are fever, headache, muscle pain, vomiting, diarrhea, stomach pain, and unexplained bleeding. Symptoms appear 2 to 21 days after exposure. Usually they appear within the 8 to 10 days after. There's no cure and no treatment at this time, although there are a lot of experimental treatments that are being tried and there is no vaccine. The current fatality rate in West Africa is 70%. Those who live more than a week are more likely to survive, and I'll also say that those people who get into care early on in the course of the disease are also more likely to survive. People who recover from Ebola develop antibodies, and they no longer are capable of transmitting the disease. So once they're better, they cannot pass on Ebola. This is really key. Ebola is spread by direct contact with blood or body fluids of an infected person who is symptomatic, who has symptoms of Ebola. So that means you have to directly touch their blood or body fluids with a broken skin or your mucous membranes of your nose, your eyes, or your mouth, or you need a needle stick. It's not spread by the air, and it's not contagious before symptoms appear. So if someone is infected but they haven't started having symptoms yet, they cannot spread it. Why is our outbreak so large in West Africa? Basically, they don't have enough resources to control the disease. The most important way to control the disease is to isolate people from direct contact, and they just don't have the amount of hospital beds, they don't have gloves, they don't have gowns. So it's close to impossible for them to isolate their infected patients, and then it gets spread to more and more people. It's also easy to cross borders there. People have a lot of distrust of the healthcare system there, so sometimes they don't even go to the hospital, they stay at home. There's a lot of stigma attached to Ebola, and a lot of distrust of the government and outsiders, and lack of knowledge, so people don't really understand how it's spread. These numbers I think are a little old, but there have been over 9,000 suspected and confirmed cases in Africa and over 4,000 deaths. Most are in Liberia, then Sierra Leone and Guinea. Other countries have had cases, including Nigeria and Spain, but they don't have ongoing transmission. Also in Senegal. There have been 4 cases diagnosed in the U.S. One was a traveler, two were travelers from Ebola-affected countries. Sorry about that. One, as you all know, died in Dallas, and the other is currently hospitalized in New York City. And 2 cases were acquired from the Dallas patient by nurses who were taking care of him, and they had both recovered and are discharged from the hospital. And there were 5 cases that were transferred to the United States from West Africa just for care. Okay, so the New York City case is a physician volunteer who returned from uni. He tested positive on October 23rd and is currently in the hospital. As soon as he had a fever, he called his organization, who then called the health department, who then called EMS, who then picked him up from his apartment and transported him to Bellevue. His close contacts, of which there are 3, are currently being quarantined, and they are being checked on at least twice a day with temperature checks. So we want to make sure and emphasize that the risk to the average New Yorker is extremely low. So we're working closely with the CDC, other federal agencies, the New York State Health Department, hospitals, et cetera, So we're all trying to coordinate to get appropriate infection control standards at the hospitals, guidance for the hospitals and healthcare workers. We've developed the capacity to test for Ebola at our public health laboratory, which speeds up the diagnosis by almost the whole day. We're definitely doing a lot of outreach to immigrant communities from West Africa, letting them know that they should seek care as soon as possible. They will not be questions about immigration status. They won't have to worry about paying for their care if they can't pay or don't have insurance. We're developing educational materials and giving presentations in several languages, and also working with staff at the Air Force and with the EMS. So if you want more information, you can go to nyc.gov/health. That's being updated every day with more information and guidelines. And just wanted to reiterate Phyllis's message about minimizing stigma. It's extremely important for all of us that we not create an atmosphere of stigma and fear, because that discourages people from seeking care. And that is the #1 way that we can control the outbreak, is to get people into care as soon as possible, do contact tracing, isolate their contacts. And if we make people afraid to tell us that they're sick, then the outbreak is going to get worse. And I mentioned this already about legal status and insurance. Okay, so here are some take-homes. We are prepared to detect, protect, and respond. We're collaborating with hospitals, other agencies, community organizations. Our protocols are currently working. You can order free educational materials in different languages by calling 311. And this is a really nice little palm card that we've been passing out that you can get by calling 311 that kind of explains how to determine if you're at risk for Ebola virus. Thank you.
And if you Google palm card New York City, that will come up, so you can put that in your own. Thank you. Are there some, if aside from going on the internet, are there some phone numbers for people to call if they have specific questions?
We're asking people to call 311, and they'll direct people to the appropriate number at the health department.
Okay. Should 911 be used at all?
You should use 911 if you're sick and you need to get to the hospital.
Okay. I'd just like to add one thing. There is on the internet, and again, there's a wealth of information. If you look at the CDC website, the New York State Department of Health website, and the New York City Department of Health website, there was something that was posted, I think within the last few days, on the New York State Department of Health website, and it's questions and answers about cleanup of Ebola in non-healthcare settings. And a lot of the information relates to healthcare workers and hospitals. This actually deals with the situations that you might encounter in a residential building. I mean, it's much more applicable there. One of the questions that it answers has to do with cleaning and disinfecting. I don't know if you can comment on.
Okay, so that guidance for cleanup of, I believe that is directed at local health departments from the state health department, if I'm correct. And if there is a confirmed diagnosis of Ebola, then the New York City Health Department will clean the setting where that person was. So we don't want anyone in the community, if there is a confirmed case, to clean up blood and body fluids from a confirmed Ebola virus patient. If it's not a confirmed patient, if it's just a person in the community who has a release of blood or body fluids, like for example, vomits on the subway, then we're recommending that people use normal cleanup precautions, wear gloves, avoid splashes into your eyes, nose, or mouth, and use a regular cleaning product like bleach. And just to reiterate, if someone does throw up on the subway, the odds are extremely, extremely low that they have Ebola. They're probably drunk or have the flu.
And I take that your recommendation is that professional cleaning contractors be used if there's a confirmed case.
Yes, definitely.
Okay, thank you. Okay, before we go to bioterrorism, Philip Hecht of Howard and Hecht, who deals with, among other, disaster response. Do you have any comments or?
Yeah, I do. And I want to thank Margie for asking us to come today. I think it's an important concept when you address infectious diseases and any type of impact event, impact threat, any type of disaster, and there's probably a dozen different challenges that residential properties can face. The greatest disservice management leadership in and around property management can do to the property and community support is do everything in vacuum. We happen to be a boutique consulting firm, and we believe that the concept of resiliency, which I can tell you from 30 years in this work, that I'm thrilled to see the City of New York remaining vigilant about the concept of resiliency. One of, candidly and unfortunately, the toughest communities to come around to the concept of integrated resiliency, which, by the way, could include anything from hazmat challenges and cleaning to power outages, bomb threats, extreme weather events, road behavior by an owner, road behavior by an employee, and I can go on and on. It's important that the concept of resiliency actually, for the best protection of the building and the property, is to integrate these disciplines and have an integrated response that candidly really gives you a set of actionable emergency protocols. Each building has, and each property, and each company, and each municipality, and I've worked with everyone from the UN to 100 foreign governments. And I can tell you each and every setting is unique in its own way. So the challenges are different. So it's, again, a relative disservice. Any planning is better than no planning, but planning without compensating for the uniqueness of the challenges is undeserving the property. And we believe, and we have, included pandemic planning as part of an overall resiliency and emergency preparedness plan for properties. It's a tough challenge because we know that a residential property is a unique animal. We handle all of our other markets very differently because boards and volunteers, they don't get paid. There's property managers and there's owners. So you're coalescing a group that reacts differently than most commercial and municipal settings. Having said that, it's wonderful to see that many of these boards and buildings and property managers are coming around. I'll leave you with one concept, and I thank those for asking me, and the doctor can attest to this. Surgeons don't perform boiler repairs, boiler repairmen don't design buildings, and architects don't fix elevators. So if there's a challenge relative to resiliency, I'm not sure we can be self-confident and say that you can fill in the blanks of a plan that you pull down from the internet. Again, it's a good start, but resiliency is as much a discipline, the same way you've heard the terminology, disaster recovery, business continuity, business impact, and risk analysis, etc. But in and of itself, it is a very well-honed discipline with very structured approaches. And we believe that full risk assessments on properties is the only way to provide true resiliency, and absolutely including the response to anything such as infectious diseases. I'll tell you one other thing. The mayor said it best. Get a flu shot. That'll help us. Okay? Get a flu shot. Okay? Bye-bye. Get a flu shot and dramatically cut down the challenges, and concepts of climate. So, thank you. Thank you very much, folks.
Okay, thank you. Next, we're going to have Hecht Wisner speak about various terrorism issues. What Hank is going to talk about is not Ebola. So when he's going to talk about these fire hazards and what you do about it, it's not applicable to Ebola, so we don't want you to be confused about his information as opposed to what you just heard about Ebola. Okay?
Okay. Do you mind if I stand? Walk around a little bit. Margie can also assist me. One of the things I'm going to talk about is anthrax, plague, sarin gas, and how to protect ourselves from that. In the 13 years that the Kelly administration and the NYPD, they picked up 16 major attacks, Islamic attacks, radical Islamic attacks in New York City. They prevented that. One was about a year and a half ago by a guy by the name of Azizi, who was planning on using sarin gas in the New York City subway system. So, my training is basically from the Israeli Army, from the American Physicians Fellowship, and from I work with the NYPD. let me talk a little bit about what sarin gas is, so that everybody knows a little bit. You've heard about it in Syria. Acetylcholine is a neurotransmitter. It takes a signal from one nerve to another nerve. There's an enzyme that breaks that down, and nerve gas blocks that enzyme. So acetylcholine builds up, and it keeps on pounding your muscles, your tears, your striated muscles. You start to salivate. You start to have a nasal discharge. You have an irregular heartbeat, and depending upon the extent of the time that you're in the area and the extent of the strength of the nerve gas, you can go into convulsions. So what we've done is we set up a program where we teach our members how to decontaminate people upwind. It's a very important concept because you don't want to become part of the problem. If the wind, if you have someone with that's contaminated with nerve gas, and the wind, and they're over here, and the wind is blowing towards you, and it's on their clothes, you could get contaminated yourself. This is what happened in Tokyo in 1995 and 1996. We studied those Tokyo incidents, so that we want to make sure we're always upwind of someone that we're decontaminating. The way we do that is with 1 part bleach and 5 parts water, and Margie's going to come up to demonstrate how we're going to dress for that type of situation. Louis is going to help Margie get dressed up. The first thing Margie's going to do is to put on a suit, which is a tie-dye suit. So you can open this up, and I'll keep talking as you guys do this. Yeah.
When you refer to members,
We have about 1,000 resident managers who take this course. It's a 12-week course, and I teach part of the course on biological and chemical weapons. So one of the things that we teach is how to suit up and decontaminate somebody, a loved one or a member of someone's family, or how to protect themselves. It's not very difficult to do. If you don't have bleach available, you can always use soap and water. We also describe 2-PAM chloride, and we also describe an oil injector, which is atropine, which helps stop acetylcholine from being produced. But the symptoms of nerve gas are very easily defined. When you're watching TV, you could see in Syria, when they used nerve gas, how people would shake and they would drool, and their eyes would tear, and they would have bronchoconstrictions. So, Margie, if you could just put on that first layer as I talk.
okay, so at this point, there's nothing special to know?
Nothing special. Margie's going to be upwind, and she's going to just put this on with the supervision of somebody else. Someone else is going to make sure that she's doing this accurately. So she's going to put this on and cover her head. Next, she's going to put on another suit, and you can do this over here. Okay, so we're worried about, so one of the things that we're worried about in public transportation is the release of nerve gas. In the Tokyo incident, that release was not, the quality of that nerve gas, of that sarin gas, was not strong. So we had 5,000 people who drove themselves to the hospital. So the hospitals got sacked. And hospitals don't like to decontaminate inside the hospitals. They tend to like to decontaminate outside the hospitals so that the gas or the contamination doesn't come into the hospital. So Margie's going to put on any questions about nerve gas. We categorize it in three ways. Minor infection or minor contamination, which means that a person is ambulatory and breathing. The second way we categorize it is moderate contamination, when we're doing the triage. And when we do that, that person is non-ambulatory, they can't walk, but they are breathing. And we give them atropine, not atropine, we give them Ventolin or other bronchodilators. And the third people are those people who are non-ambulatory and non-breathing. We don't touch those people. We try to do the most good for the most amount of people, so we stay away from that. Okay, the next thing that Margie's going to do after she's completely covered is remove her glasses and put on this tape over here. We'll have to go around the duct tape around her wrists. And so now Margie's going to be pretty protected with a gas mask. These are very inexpensive gas masks. And they're good for somewhere about 8 hours. The problem with the decontamination part of it is that's where you get into trouble. With gas problems, you have to act quickly. With biological problems, you have time. So that's one of the things that we'll go through in the, and I'm making this very brief, in the class. The other thing that we're concerned about is plague. The reason we're concerned about it is because it's also sort of a hemorrhagic type of disease where you get DIC, disseminated intravascular coag. You bleed through very small vessels. And I guess, and I'm taking a shot at this like Ebola too, platelets, antibodies, fluids, those are all important things to replace. And it's the same thing with plague. It's called a black plague because the fingers and the nose and the ears usually turn black at a certain point of time because blood coagulates into those areas. Okay, now here's a mask that Margie's going to put on. We train people to do this in about 7 seconds. So you can put it on from your chin, first using your chin. And we test these masks by making sure that the seal is good. And what I'll do is just quickly demonstrate that because this is probably the first time that Margie has that on. You can help her. I'll show you how a seal works. So if the gas mask is on properly, take our glasses off.
The seal, you can see that if I put my hand here, and I come in, that the seal is on properly. Did anyone see that? Okay.
So all different types of gas masks. These are NBC gas masks. We like them better than the regular types of the 3M masks, this type of mask. Okay, we also consider nerve gas to be a very volatile type of substance, which means that it disperses quickly. Unless it's VX gas, which is very hard to make, this nerve gas usually not, that first responders don't normally have a problem if they're upwind of the person and it's protected in this manner. Okay, so that's what we're going to talk about. You'll have to cover that whole area. And then when Margie's through decontaminating, and when we decontaminate someone upwind, we cut their clothes from the top down so that we don't pull anything over their head. So that we don't have gas or anthrax or any other thing coming over their head. So it's always from here down. And we then decontaminate them. We wash them down in bleach, 9 parts bleach and 1 part water. So if you just step over here, Margie, for a second, Lewis is going to take this and we're going to make believe that this is a, you have to also tape your duct tape around, that's it. And the plague is also something that we're concerned about because the Russians made tons of it. And there are 3 types of plagues. There's a bubonic plague, pneumonic plague, and septic plague. And the problem that we have is with septic, with pneumonic plague, which is very transmissible from person to person. We're worried about that because it's been used as a biological weapon. The Russians have really done a lot of work with plague as well. Okay, also her yeah, she can put that on as well. The last thing we're going to talk about, so we did nerve gas, we talked about that, we trained for it, we do a little talking about plague, and we show pictures of plague, and how to work with plague. What we use with plague, because it's a biological weapon, we use streptomycin, and we use streptomycin in 15 milligrams per kilogram of lean body weight. And we do that only for 12 days. So people who volunteer to help people because there may be a plague or an anthrax outburst, those property managers take these drugs prophylactically for a certain period of time if they're going to hand out medicine to other people. And we teach them how to ballpark someone so they know how much medicine to give someone. If you're in a school setting and there's a lineup of people taking ciprofloxacin for anthrax, they'll be able to understand how to distribute that medicine and how to talk to people and to make sure that they finish taking that medicine and what to look for if there are any symptoms or problems with the medicine. The last thing is anthrax. So Margie would then decontaminate. That's pretty much the way Margie would look like. And then decontamination would happen over here with this area. Margie, if you can come around to this part over here, providing you have a good seal, you would then have someone who's dressed like Margie, and you would then wash Margie down completely, all over everything. And as he's doing that, he would also spray bleach over Margie to completely decontaminate Margie as well. Her boots would be such, she would step into this bleach for her boots. And then the first pair of gloves we put in here, into the, that's right, put it into the bleach. Okay. And that would be washed all over. Okay. Now, this, we could assume that the nerve gas that she has over here is gone from the bleach. And now, he, dressed like Margie, would help her take her clothes off. Not your mask, that would go off last. So you would start taking the suit off. Remember, she would be completely decontaminated by bleach. The first thing is unzipping her suit, and he would be dressed in a similar fashion, all upwind of the victim. The last part I want to talk about is anthrax. We had an anthrax attack probably around September 16th after 9/11. Somewhere around 10,000, 15,000 healthcare postal workers, I'm sure you all remember that, were working with gloves and masks in your buildings. And there were 2,000 cases of the FBI going around the country in a hazmat material response unit because there's fake anthrax or powder being distributed through the mail or to some people that they don't like. So you can imagine what that costs the taxpayer having planes flying all around checking on anthrax. The first thing that we would do in the CERT program, we were in a building with anthrax, is shut down the ventilation system. In the Senate Hart building, when a lady opened up the Dashiell letter that had anthrax, it was 40 minutes before somebody thought to shut down the ventilation system. It cost $26 million in 6 months in order to decontaminate that building. So shutting down the ventilation system is very important. And anthrax also, there are 3 types of anthrax. There's a septic anthrax, which we really don't go into. It's a food-borne situation. A cutaneous anthrax, and one of the hijackers went to the FDR Kennedy Memorial Hospital in Palm Beach County with cutaneous anthrax before the 9/11 event. It should have been a reportable disease at that time. For some reason, this guy picked it up as anthrax, gave him medicine, but didn't report it. Had that happened, maybe we would have gotten more information about 9/11. Also, Mohammed Atta in Lantana Airport was looking to rent crop dusters. So, and it was only about 2 weeks later that we had this anthrax attack in New York, which affected and scared a lot of people. We use ciprofloxacin. It's a hard bacteria to kill because it's a spore type of bacteria. It could live in the soil for a very long period of time in cold, dry climates, and you have to take it for a very long period of time. So anthrax is another concern that we have. The last concern that we have is hydrogen cyanide. What terrorists are doing, and they're called mutangs, that came out of Pakistan, is they're taking things that you can buy in hardware stores, rat poisoning, which is sodium cyanide or potassium cyanide, crushing it, and then mixing it with battery acid. And that combination produces hydrogen cyanide, and that's what kills people. The ventilation systems in your buildings are important to watch. If you have that type of situation where there's a backpack and it's leaking fluid and it's near your ventilation system, it's a problem. Or if you see a condom stuck into the ventilation system, what they do is they crush that powder, put sodium cyanide in it, and then they take another condom and they put battery acid around it. They put it into a ventilation system. The first thing to do again is shut down the building's ventilation system. So those are some of the things that we do in our course. It's a 12-week course, and Margie knows about it. We can start taking her suit off now. The last thing that gets taken off is her gas mask. Not yet. First take the suit off if you can. That should have gone underneath. Okay. And then the gas mask, and then the gloves again are put into a bleach solution. And then the gas mask is then taken off, and then we encourage her to take a shower. Any questions about what we do in the CERT program? Okay. Okay, thank you very much.
Thank you, Hank. VLehr is the engineer on our panel. We now heard that's an engineering issue, Val.
Okay, thank you. I'm a consulting engineer, and we do a lot of work in hospital design and isolation wards in hospitals and special ventilation systems. So just an interesting point about shutting ventilation systems off. If you introduce a contaminant at a source point, at the entry point of an air conditioning system, in general, it is dispersed throughout the air conditioning system in something under a minute. The normal distribution, if you put it in at the air intake, is about 45 seconds, and every portion of the system that it's served has air distributed into it. So moving quickly on that is extremely important. So this is an interesting point of view. But we've been working, and I've personally been involved with projects in West Africa and Central Africa since about 1971. Ebola is only one of a wide variety of really unusual and dangerous diseases that are all over Africa. And I think the advice that we've gotten today about listening to public health authorities and believing them is very important, because that's one of the main mechanisms that cause these diseases to be spread. There is wide distrust, and it's that distrust which is, in fact, aiding and abetting the spread of these diseases. And, you know, if we follow the directions and believe the directions, we're much better off. Now, I can also tell you that we're involved in projects in two of the main infected countries, in Guinea and Sierra Leone. And what we're doing is we have come up with a mechanism of building a complete isolation facility in those countries, and the isolation facilities are intended to house and treat people who have the disease and who are afflicted by it. And those isolation facilities are badly needed because we've been to these areas that just don't have that kind of facility. And the other point I think that's of interest is that there's some confusion, I think, in the idea of an isolation facility as opposed to quarantine. Isolation is something that is extremely complex. It deals with making sure that the sources of air are 100% controlled. It deals with the fact that air that's exhausted has been disinfected first. It has separate power and water supply, and even deals in the isolation chambers that we're dealing with treatment of the bodily waste that come out of the sewage system. These things are very complex. They're very different than the concept of some sort of not isolation but quarantine. And quarantine is, again, if you follow the instructions of public health authorities, I think works out quite well. So in the end analysis, I think there's always a tendency of someone who says, well, maybe I can do something myself. Please reject that, because it's very difficult to do something effective if you don't become expert at it. I think the demonstration was quite interesting to see how complex it is just to suit up and to unsuit. Imagine trying to do something more complex than that is very difficult. But I think the message of trust public health people and follow their instructions is the best thing to do, because again, over 40 years of experience in Africa, following those instructions and those dictates has been quite well, because of myself and quite a number of my colleagues who work regularly on projects in those areas have survived very well by following instructions and believing them. Thank you.
Thank you. Mardi-Ellen.
Hi, my name is Mardi-Ellen. Actually, I'm a professor and a specialist in communications and language, and I also build software and wetware systems. I work with architects on my team. I'm a creator of programs, and I work with architects and engineers. And I'd like to, I found this very, very interesting from just a very basic communications idea. And it was very instructive for me personally to listen to these experts speak to not only the issue of Ebola, but other diseases, and the idea of what information means, big topic, right? What big data means in the face of being afraid, being isolated, and what that means to people living in a building, potentially being quarantined, and how people respond. As Phil said, you cannot respond in a vacuum, because we're not living in a vacuum. So basically, what you have here is a global problem. We're living in a global world, but we live in the United States. And Phil and I actually were discussing yesterday a bit, thanks to Phil, I was informed very well about the idea of policy and how policy making is not uniform. It can't be. We live in the United States. We have state government, we have city government, we have federal government. We are listening to all kinds of information on the radio, on the internet, from our friends, from our professors, and the issue becomes a decision-making response on your part and what that response time means and who do you listen to. I found this gentleman speaking, sorry, Valentine, be very explicit about who to listen to. But then, one has the idea of being pulled to the internet, right? To one superior in the job, to the governor of a state, to the mayor in a city, to the president, to the global news, and we have enormous conflicts here. I think the big message here is trusting one's instinct and leaving it to the experts and then deciding way beforehand, not at the time of a crisis, who those experts are going to be that you're going to be leaning on, because we are living in this very fraught environment where fear can be used in a good way, meaning it's important to be afraid of something that can harm your body and harm your business and harm your reputation and harm your data. But that fear can also be the mode for stigmatization, and I found that absolutely the most important thing that was said here, because I'm a New Yorker from birth. I do remember that AIDS epidemic. I do remember Legionnaire's disease. I do remember West Nile virus, and how these things come in a sequence to us here, especially in New York City, where we have big advantages in terms of the technology we use and how fast we pull it. So being somebody who deals both in virtual time and in real time, I'm very aware of that interactive behavior in everyone's part of the decision-making process to grab for a piece of technology that will give you the answer. Let me say to you, I deal in the most advanced forms of wetware and software. There's nothing more complex than the human brain. And I just want to leave you with that message, because I think that every expert here had something really powerful to tell you.
Okay, do we have any questions?
Yeah, with Ebola, when someone is no longer infected, in the semen of men, how long does that virus last?
That's the question. There is data that once a person recovers from Ebola, it's not in their blood, vomit, or stool anymore, but it is in their semen for, it's an unknown number of days, possibly a week, possibly 2. So the Centers for Disease Control recommends that men who have recovered from Ebola refrain from having sex for 2 weeks after they recover.
Any other questions? Yes.
I just had a quick question regarding who would bear the cost of the Ebola cleanup from a confirmed.
Can you go to
Sure.
the mic, please? Yeah, please, anyone that...
Well, okay, the question, if I understood it, was who bears the cost of an Ebola cleanup?
Yes, who would bear the cost of an Ebola cleanup in a residential multifamily scenario where there has been a confirmation of infection?
So that's a very specific question, I like that. So if there is a confirmed Ebola virus case that requires cleanup because of blood or body fluid contamination, the Department of Health will bear the cost for the cleanup. If the case is not confirmed, then the cleanup is the responsibility of the property owner.
Or it might be, depending on if you're in a co-op, a condo, or rental building, it may be the cleanup cost may be passed along, and that would depend on the documents. I believe there was an article in the New York Times 2 days ago about the cleanup that was done after the doctor who's now at Bellevue was diagnosed, and the cleanup in his apartment and bowling alley, and I'm assuming that was all city expense?
The cleanup in the apartment will be paid for by the city. The bowling alley hired a contractor separately, and the city will not be paying for that cleanup because there was no evidence of blood or body fluid contamination at the bowling alley. The city actually recommended to the bowling alley owner that he use normal cleaning and disinfection techniques, so a 10% bleach solution would have been fine. He chose to go to the next level, and that's totally his choice, but he will be paying for that.
So can I finish on that? I think the doctor highlights a very important issue, and that is the complex challenge of media and reputation and true fact. It is quite possible if there was an ongoing media frenzy without clarification, the business of the bowling alley could have been shut down. The damage to reputation is extraordinary. From a practical standpoint, for property managers and owners, the best thing to do, and I believe Val just said it a little while ago, is not do it yourself. And the reason you don't do it yourself, once again, is you need to be cognizant of the challenges unique to the property, you need to be cognizant of the direction that your experts in the city provide, and most importantly, you really need to have a set of preparations on what to do next. Knee-jerk reactions are challenging at best. But on a personal level, each of us know that owners of condominiums and co-ops at one point or another are going to be deeply concerned about their valuations. And if there is a challenge in a reputation being impugned by misinformation, that could be really spun out of control by the media, you face some significant challenges. So the sooner you have a plan in place and you take the advice of the city, you have a greater chance of protecting your reputation of the property.
Yeah, I think that over the course of my practice, and I represent boards of co-ops and condos primarily, there have been situations where suddenly people appear in hazmat suits at the building. It's because of mold cleanup, and there's all of a sudden, that in and of itself creates panic. And so it's what do you tell people, how do you handle it? So you really need to think it through. Think about some of the buildings where there have been bed bugs, right? And the kind of panic that you have there. Now, bed bugs are a health hazard. For those of you who are in co-ops and rental buildings but not condos, bed bugs are deemed to be a breach of the warranty of habitability, and so can have legal and financial consequences to the owner. They pose problems. I had a situation recently where there was an apartment that was infested. The building cleaned it out because the shareholders refused to. It was used a professional contractor to clean up the apartment, and then the shareholders kept on reintroducing bed bugs. And at the same time, there was a very serious leak in the apartment, and the leak was going into the apartment below. And the building called the plumber. The plumber went to the apartment, actually saw bed bugs, he says. I don't know, somehow knew the apartment was infested, and said, I'm not working here. And ultimately what had to happen is the restoration company had some kind of, protective clothing that was given to the plumber so the leak could be fixed. Meanwhile, rumors are flying through the building. You've got people in protective clothing, you've got bed bugs and whatever, and sometimes you have to manage that because, that gets out into the broader universe. The problem was ultimately solved, both as to bed bugs and the leak, but those are the kinds of issues, unfortunately, that you have to deal with. And really, in this whole conversation, bed bugs shouldn't be forgotten. They're transmittable from one apartment to another. It's not like a contagious disease, but it is a problem. So. Any other questions?
And I'm always confused about what it meant, what body fluids meant. Okay, I'm assuming that it means sweat, blood, tears, nasal, saliva, urine, vomit, diarrhea, that type of body fluids. My question is, if it's body fluids and you're sitting next to someone in a plane and they actively have Ebola and they sneeze on you, even though there's no airborneness to it, can you contract Ebola by having someone who has an active case with a high viral load in their blood and in their saliva? Could that get into your nasal passages? And could it be possible to contract that like that?
As far as I know, it's never been shown to happen before that a person who was sneezed on or touched a door handle or shook hands with someone who had Ebola contracted the disease. The evidence we have based on the epidemiology of the disease in West Africa and what has happened here in the United States in Dallas, in Atlanta, and in Nebraska are that you need to have close contact with a body fluid like blood, vomit, or diarrhea. And it's difficult to say there's zero chance, because there's never zero chance, but it's extremely, extremely difficult to contract Ebola just by brief casual contact, like being sneezed on or sharing public transportation or shaking hands with someone.
I think that the experience in Dallas might bear on this. I know this is not scientific, but had an Ebola patient who died there who had been in an apartment with family members, including his fiancée, for several days before he went to the hospital. And they were all quarantined, and the 21-day period has passed, and none of them, not one, contracted Ebola. And you would think that would be, at least in my layperson's mind, I would think that would be far more likely in terms of transmission than
Being casual.
Yeah.
Yes, I totally agree.
Any other questions?
Did they ever figure out how the nurse in Texas picked it up?
So the nurses, they did an extensive debrief. The Centers for Disease Control went to Dallas and spoke to the nurses. And neither nurse remembers a moment when they had direct contact with blood or body fluids. So the best guess at this point is that the nurses somehow contaminated themselves when they were removing their personal protective equipment, which is difficult to do if you're not trained properly, as we saw earlier. And Centers for Disease Control has done some education in the Dallas hospital to make sure that every time someone is in that situation where they're wearing that kind of high-level personal protective equipment, that when they take it off, they are taking it off in front of an observer who is also wearing protective equipment and who can notify them immediately if there's a breach.
Any other questions? Okay, well, thank you all for coming.